So thank you everyone for coming. I'm Alexandre Bani-Sadr. I work as a neuroradiologist in Lyon, in academic hospital dedicated only for neurology, and I'm glad to present our research entitled Oxygen Extraction Fraction Mapping, a potential predictor of post-thrombectomy brain lesion recovery. So the article has been published in Stroke on last November. So let's get started. So as you know, in acute ischemic stroke, reperfusion therapies, so thrombectomy and thrombolysis, aim to salvage the ischemic penumbra, which is the salvageable tissue. With MRI, we use diffusion-weighted imaging to estimate the ischemic core, which is presumed to be irreversible. However, in our daily practice, we can find that DWI lesion may recover after reperfusion, like you can see on this example. Sorry. Over there you have a lesion. So over there you have a lesion that is supposed to be dead, and after reperfusion you get the recovery. So when you look at the history, positron emission tomography was the first and is still the most accurate technique for mapping the ischemic penumbra, which was defined by a region with a decreased cerebral blood flow, a high OEF, and a preserved cerebral metabolic rate of oxygen, as you can see there. So this part is supposed to be viable. The problem is that in clinical setting, we cannot do PET for stroke. Now, if we looked at studies comparing PET and MR, they have shown inconsistencies in the assessment of the ischemic penumbra. In some part of the DWI lesion, there were an increase in OEF, which is not consistent with the fact that dead tissue should not consume oxygen. So the objective of the study was very simple. It was to assess the fate of DWI lesion with high OEF after successful thrombectomy, using DSC MRI to compute OEF maps. So that was a retrospective study from a single center cohort, which is called Hibiscus Stroke cohort, where the patient had first MRI at admission, then they undergo thrombectomy, and then at day 6, they undergo a second MRI with T2 flare to assess the final lesion. From this cohort, we included patients who achieved successful thrombectomy, which was defined by a MTK score of more than 2B, and who have undergone DSC MRI at admission and also a day 6 follow-up MRI. We performed vision analysis, which was very simple. So as you can see on the left, there is the DWI lesion, and there is an increase of OEF compared to the contralateral side. So this patient was classified as patient with OEF increased within DWI lesion. Conversely, those when that was not the case, they were considered not increased. We also performed voxel-based analysis, where we measured OEF values in recovered versus non-recovered DWI lesions. So if we look at the results, we included 134 patients with the following characteristics, so mainly small lesion. We observed that there were almost 33% of patients with increased OEF within DWI lesion, and the volume change from HGO to day 6 was negative, so the ischemic lesion decreased. That was not observed in the patient without increased OEF. So just a simple example, as you can see there, the DWI lesion is quite extensive, and we can see that there is an increase in OEF. So basically, this patient is not a very good candidate for thrombolysis or thrombectomy because the irreversible tissue is quite large. So he achieved successful thrombectomy, and as you can see, there is a huge reversibility of the ischemic DWI lesion. Here, a counter example where you can see the DWI lesion without increased OEF. So, at follow-up, the lesion remains stable. When we look at subgroup analysis, we observe that DWI lesion recovery increased with larger lesion size at baseline. It means that the more the lesion was big, the more it undergo a decrease. And we also observe that DWI lesion recovery increased with a higher degree of recognization. It means that for patients achieving complete reperfusion, they had a greater decrease of the final lesion. When we look at multivariable analysis, we try to answer to the question, what are the factors associated with an increased OEF within the DWI lesion? And we observed that that was associated with a regression of the lesion. For voxel-based analysis, we found that recovered DWI lesion showed increased OEF, while non-recovered ones had decreased OEF. And 95% of DWI lesions with increased OEF were recovered by day 6 after successful thrombectomy. So we can say that OEF mapping may predict the recovery of ischemic DWI lesions. But why does it matter? As thrombectomy is increasingly performed in large core OES, there is a huge need for a more precise assessment of irreversible injury. So biomarkers like OEF, which can assess the viability of the DWI lesions, may improve patient selection prior to reperfusion therapies. So now what we're looking currently is to assess the perfusion-diffusion mismatch zone, since despite successful thrombectomy, most patients experience infarct growth, which correlates with poor functional outcomes. So as you can see, in this patient, there is a very small amount of DWI lesion with the perfusion deficit. He achieved an empty kit score of 2C, which is almost complete, but at the end, there is a large lesion. So what we found is that this correlates with the collapse of CMRO2, as you can see there. So the collapse of CMRO2 is associated with infarction despite recognition, and this implied that CMRO2 mapping may be an earlier marker than DWI to predict infarction. Thank you for your attention.
Thank you, Dr. Bani-Sadr. Thank you, Alexander, for the great presentation. I think at Cercare we aim to use clinical available information and make really good perfusion maps and enhance it with novel biomarkers. And I think your work is a great example of how those can be used to answer highly clinically relevant questions. So thank you for the great research. And if there are any questions that can exceed the level of the fire brigade, that would be great.
Great work. What are the sizes? They were very small infarcts.
For the most of the study population, it includes hyperacute stroke. But what I didn't show to you is that we have maybe 20% of patients with large core, and it works almost the same.
And that was my question. If you think there is a difference in predictability with bigger infarcts than smaller?
The more we observed that the more the lesion was big, the more the reversibility was big also.
And did you compare what was the CBF less than 0.3?
Yes.
And how did that compare?
We compared CBF and OEF at voxel-based analysis. So the recovered lesion had a less severe impairment of CBF, but there is a significant overlap between those that was less important compared to OEF.
So this is better. OEF is better than the CBF.
Yeah, OEF is a better discriminator of recovery compared to CBF.
Thank you.
Thank you.
Were any of your trial patients on a certain last known well or time? You know, where did you have a 6 or 8 hour, 12-hour window, or any of them?
So almost 1/3 was unknown symptoms onset, maybe, and 10% were more than 6 hours, and the remaining were hyperacute. Thank you.